Now we're going to migrate from research at the molecular level to research at the very physical level. Dr. Claudio Tatsui is a spine surgeon here at MD Anderson and is going to be talking to us about new techniques to treat spinal tumors using thermal ablation, which is quite an interesting new frontier in the potential treatment of chordoma. So, Dr. Tatsui, nice to have you here.
All right, thank you very much for the invitation. This is a great conference. I think we all learned a lot, and it's a pleasure to be here. So I'm going to be shifting gears a little bit and talk about some of the techniques that we're using to treat some of the spinal tumors, and we have adapted a couple of things that we learned on the brain to the spine, and we have applied this on the setting of chordoma as well. So first I'm going to touch gears on this is the traditional way that we treat chordoma. Chordoma is a primary tumor, meaning it arises in the spine, and if we remove this tumor with a margin of healthy tissue around this tumor interior, you're making the patient cancer-free. So that's the goal of surgery to treat chordomas on the spine. And as you can see on the curve here that we're showing here, this curve shows a difference in survival. Patients that you can achieve a resection like this that Dr. Ryan's achieved survive better or survive longer than patients that we couldn't achieve a free margin. Okay? Unfortunately, when I'm talking to metastatic disease from other types of cancer, this surgical aggressiveness not necessarily translates into a benefit in survival. Actually, it's the opposite. This is one of my projects when I was a fellow. I looked into 267 patients with kidney cancer that had a metastasis on the spine. And in situations like we see on the top, when you have a lung nodule or when you have skeletal involvement that progresses before your spine surgery, these patients have 4 times more chance of dying after the spine surgery than patients that had stable disease. And that was true for other histologies, like thyroid carcinoma. We looked into melanoma. We looked at sarcomas, and this was a very consistent predictor of survival after surgery on the spine. And that's because those patients, they have cancer progressing. So we have to stop. If they undergo surgery, you have to stop chemotherapy. They stay a few days in the hospital. Sometimes the hospital stay is complicated, and there is even longer interval to recover from surgery. After surgery, usually we treat these patients with radiotherapy that takes about 10 days to be completed. So we're talking about resuming systemic treatment a month or even longer than a month. So all this can be very variable, and the longer for these patients to return to treatment, the worse is the prognosis. So that's why I got interested in developing less invasive techniques to treat patients. And there is basically 2 reasons why I'm going to be doing surgery on patients with a spine tumor. One is to stabilize the spine, and the second one is to decompress the spinal cord or the nerves. So I came from a background on the degenerative spine surgery, and we developed ways over the last 20 years, new less invasive techniques to stabilize the spine has been developed, and this is one of the ways that I got very comfortable doing. This is a patient with systemic breast cancer, pretty much almost every single bone affected, but there is an outlier. There is one level there on the spine that is mostly destroyed, and she couldn't stand up because she was the gravity would cause a lot of pain to her. So what we did was, with a little needle, we injected cement on that level, and that reinforced that bone, and she was able to then improve her pain, and she started chemotherapy 1 week later, and she's alive up until today, 2 years after that. So if I was too aggressive in that situation, maybe I would have a complication, she would have a delay on systemic treatment, and maybe the story would be different. Okay? So after doing that, we started applying this a little more in more complicated situations. This is another example. This patient has lung cancer, and he's not doing so well in terms of performance. We have a scoring system. He's on the 50%, meaning that he needs assistance for almost all his activities, and he has progressive disease. We already shown that patients with progressive disease, then survival is worse. And if we do an aggressive surgery here, we might not having him very well served. So what we did, 3-level fractures, we were able to stabilize very with a less aggressive procedure. So this is how we do. We position the patient. We use a fluoroscope, and we have a tool called the neuronavigator. So that's like a GPS tool. And then with that, I can do smaller incisions, and I can go straight exactly in the point where the screw has to go. And we do incisions the size of the screw that we're going to be using. So after putting a reference array on the patient, we can use the computer to calculate a model of the spine, and can guide us with a very small incision exactly in the bone where we need to put the stabilization screws. Then we have a needle. Then we change this needle to a guide wire, and the screw, and then the guide wire I can use to put a needle that I can use to inject cement, and then I can put my screw. So that creates a very strong reconstruction of the spine. So this is once I set all my needles on the levels that I want to instrument, I can then inject my cement. On the left here, you can see the black in the vertebral body. That's a cement being injected. And on the left side, you can see I can exchange my needle later to the screw that is connected to an extension cannula that helps me align the screws. So after I inject my cement, I can then drive my screw through the guide wire that lands on the cement. And then I can use the extension towers to guide me for the rod. And on the end, I have this long stabilization with only 4 little incisions. This patient recovered relatively well. He went home in 3 days, and his pain from an 8 dropped to 4, and he was able to continue his treatment. Now we have this intraoperative CT. I think Dr. Rines has showed probably this on his talk, and now we can do this even more precisely. Before I was using X-rays, now we can use even a CT scanner, which allows me to do even more complicated reconstructions, especially when I have deformities and malalignments on the spine. So we can stabilize the spine with less invasive surgery, but can we decompress the spine with less invasive procedures? And this is what I'm working over the last 3 years, and we put together this in a few publications, and we were able to achieve the cover of the 3 most important journals in our specialty, and we are using this treatment in combination with stereotactic radiosurgery, which was already discussed here before. So basically, the idea is that we are going to put a laser catheter, you can see on A, inside the tumor, as we show on B, and number 3 and number 4 is the real image of the heat when the patient is in MRI. So when you hit the tissue, the proton, the water changes, and that changes the signal, and that can be captured on the MRI and converted into a thermal mapping with the precision of 0.1 Celsius. So if we can calculate mathematically the temperature based on the changes that we see on the MRI signal. And so the idea is that you have, on the left here, you have a spinal cord compression. That's the circle is the spinal cord. There is a tumor near there. I can definitely treat most of the tumor with stereotactic radiation, but the part that is touching the spinal cord gets, I have to reduce the dose of radiation in that area. And when I reduce the dose of radiation, not necessarily I kill that tumor. So the idea is that we're going to put a needle. We're going to insert our catheter right there, and we're going to hit and destroy that part that is near the spinal cord, and then we're going to treat everything else with radiation. So this is an example where I have a tumor compressing the spinal cord. I have to treat, the spinal cord can take more than 12 grays of radiation. So what we do, ideally, we need to give 24 grays to control this tumor. However, there is a region here that can't be receive 24 grays, otherwise I'm going to hurt the spinal cord. So what we do, we put our laser catheter in the middle, and the idea is that we're going to destroy that part, and then we're going to, and this on the left is the immediate post-op, meaning right after I did my burn, you can see right away that we destroyed that part close to the spinal cord, and then we can treat it with radiation, and I'm going to show how this is done. So basically what we, in order to do this procedure safely, the laser is not new, but monitoring the temperature is very new. And that's what makes this procedure feasible. Otherwise, I'm going to be hurting patients by causing thermal damage to the spinal cord. So we have the magnet, and then I have this trolley. I can bring the patient in and out. So when I'm using instruments that are not compatible with MRI, I can bring the patient outside of that yellow zone in the floor. That's a safe zone. I can work with non-MRI compatible instruments. And then when I finish my fiber placement, I can take the patient back to the MRI. So we did some research and ways to use navigation, that GPS tool that I showed before that was designed to be used with CTs. How can we do that with MRI? So we applied these markers that we can see on the MRI, and we did some tests, and we were very accurate with our tests. This is an example. I have the needle inside one of those donuts, and then I can precisely show that it's inside the donut. And then we created a research protocol, and we applied MRI to do guidance on the spine, which is, to my knowledge, never been done before. So I'm going to show an example. This patient has kidney cancer. I treated her 3 weeks ago. So you can see she has a tumor on T12, and that tumor is compressing the spinal cord. So we bring the patient to the room. We put the markers in the patient's back. Then we have this little clamp that we apply on the bone, and where we can put our reference. Then we cover the clamp, and then I put an MRI coil. I am sure most people here had an MRI before. Without the coil, I can't really do the imaging. And that coil it can't touch the markers. Otherwise, if they change the position of the markers, then I'm not going to have a precise navigation. So after I prepare the patient, I take the patient into the MRI, and we obtain an image with the patient in the operative position. You can see on the left here, there is the 2 markers there visible on the scan. So then I bring the patient outside, and I tell the computer exactly where each marker is located. So you see on the very top, I'm touching the 3rd mark that goes in a row. The computer recognizes that and stores the coordinates, and by triangulation, it creates a virtual needle that shows the trajectory that I want to follow. Okay. Then I use that to plan my incisions, and it's hard to. There is no mark, but there is 3 little dots that's going to be my entry points for my laser fiber placement, and I have marked 4 incisions that's going to be where I'm going to put my pedicle screws. So then we prep the patients. On the left here, I have the needle with the spheres. The computer is triangulating my target, and I have the needle exactly inside the tumor on that image. Then I exchange my needle to an MRI-compatible needle. Then we cover everything sterilely, and then we go back to the MRI. Then once we go in the MRI, I need to find exactly where each needle is located. So this is an example where I did that. And that's an example of my computer showing me my trajectory. In blue is the needle. In yellow is the length of the spread of the heat. So I try to keep my needle 5-6 millimeters lateral to the spinal cord, because the heat is going to spread on that region. And this is what the computer was predicting, and then I added where the needle was located. So I was very precise in my fiber placement, and I was able to put 3 fibers with the same precision. Okay. So after I identify exactly where each fiber is located, I can then burn on the exact plane of each fiber. So then we put our laser catheter, and we go back to the MRI. Once we identify where each catheter is located, we can monitor the temperature. So I select a point to monitor my high temperature. We set that to 90 Celsius. And then we select points in the junction of the tumor to the spinal cord, and we don't want the temperature to go more than 48 Celsius in there. Okay, so after selecting these points, then we can start the system. And we need to stop the ventilation when we do that, because motion creates artifacts, and I can't have a reliable thermal mapping. So the anesthesiologist has to stay inside the MRI room during the scan. And this is an example in real time. So as you can see, the blue that is appearing there, that's the temperature in real time. And when we get 50 Celsius on the top, the system stops, shuts down. So that's how we perform our laser treatment. So this is happening. We're destroying the tumor, and then we can move to the next fiber. And as we are firing the laser, we have a mathematical model. Every yellow dot is a point in that, is a pixel that got to the temperature that kills cells. As you can see on the right side, This, on the left side, is the post-treatment scan showing the destroyed tissue that is dark, correlates very well with the predicted model during the treatment. And these are my post-treatment scans showing before and after. You know, before, when we give contrast, you can see that the tumor enhances with contrast, and there is a very nice area of necrosis near the spinal cord. And you can see that on axial cuts and on sagittal cuts. So we were able to achieve destruction of the entire tumor that was touching the spinal cord. This is another example to show the fibers and how we destroyed in a coronal plane. And after I finish that, I can put the patient all the way back outside of the magnetic field, and I can put the screws like I described before with the small incisions that I have already marked. That's the patient the next day, very happy when she went home 2 days after the procedure like this. And traditionally, patients stay like something between 5 to 7 days, and then they have to go for radiation, and then they have to go back to his treatment. This lady went back to treatment in 3 days after the surgery. And we showed in our series that differently than open surgery, when you have increasing pain in the first week and then the pain improves after, we don't have a spike in pain. So we can do this procedure. We have very little impact on the patient's quality of life. Actually, after we start treating, we treat with radiation, the pain scores even get better, and the quality of life, as you can see here, doesn't get affected by our surgery, by this less invasive procedure. So we compared the results of surgery that we have been performing on the same time interval that we're performing these laser ablations. This is not a very it's not a matched cohort, but just to give an idea. And we are going to be doing a prospective study where we're going to select patients that could be treated by either technique. But just to give an example, if you see the days in the hospital, patients stayed a median of 3.4 days versus 12 days. So we were able to move these patients out of the hospital faster. The interval between the procedure and the radiation was 1.8 days versus 40 days. And the days to start chemotherapy, 25 days versus 62 days. So we showed an advantage in terms of recovery after this procedure. Okay? And I'm going to show, we use this technique to treat one patient with chordoma. So far, I've treated just one patient, but I can see this being used for the recurrent chordomas or for a metastasis of a chordoma where you don't want to do an aggressive surgery or when the patient has other priorities. And this is the example. This lady has been treated many times. I think she had like 6 or 7 operations, and she had that metastasis on the spinal process of C7. Technically, that's a difficult needle placement. The only way I was able to do it using MRI guidance. As you can see here, that's the X-ray showing my needles in the place, and that's the MRI localizing my needles. I was able to precisely put the needles inside the tumor. Then we performed the laser treatment on the right side. You can see the black area. That's the area that we destroyed with the laser. And after that, we did stereotactic radiosurgery on that patient. This is the pre-op. That's the immediate post-op, and this is almost 2 years after. This patient has local control on that spot. And that's the proof of principle that we could use this eventually for depending on the selection of the patient. This might be a viable tool that we can use. So just to conclude, with this technique, we are able to do a minimal delay between the stereotactic radiation and chemotherapy. We had a short hospital stay. We had an effective improvement of pain, and can be performed in conjunction with stabilization of the spine. And the question that remains to be answered, and we're going to be working on this in future studies, is to see if we are really improving the local control, adding to the efficacy of stereotactic radiosurgery. Thank you.